and unmuted.
Oh, there you go.
So I have just a small number of slides. I didn't want to take up too much time. Us academic folks do that sometimes. Just want to present some basic data. And also, I've noticed as we've been going through the day, there are reminders of things that others have said, sort of presenting from different perspectives. But, you know, the data are basically what they are. And so we keep hearing, you know, different versions of some of the same information in different ways. Next slide, please. So I thought, particularly having a presenting partner here who's done work not only in HIV, but also in cancer, that it may be that while folks know a lot about differences between the LGBT community and the straight community when it comes to mental health and substance use, there might be a little bit less knowledge that there are also disparities in a variety of other health conditions. So this is national data, but I promise you the data in Detroit are very similar. So for these 5 chronic conditions, and I will say this, LGBTQ is not just one letter, it's 5. But to get this down into 4 or 5 minutes, I'm just doing the whole group of lesbian, gay, and bisexual, because this is how the data are collected nationally. Data collection is not what it needs to be, especially for the trans community. And so I apologize for that, but using the best data that are available at a national level. Asthma, about 30% higher in lesbian, gay, and bisexual community. Cancer, about 20 to 25% higher. Heart disease, about 10 to 15% higher. Diabetes, about 10% higher. Hypertension, about 6 to 8% higher. I'll talk very briefly about why would that be in a couple of minutes. Next slide. These are the data I think that you've heard more about today and that we're even more familiar with because they're really terrible. I mean, these disparities are not 10, 15, 20%. They're, you know, they're 2, 3, 4, 5 times different. Current mental illness, more than twice as high among lesbians, gay, and bisexual community than heterosexual. Serious mental illness by diagnostic criteria. This is from the National Survey of Drug Use and Health, 4 times. Illegal drug disorder, not just use, but disorder, about 3 times the rate. Alcohol use disorder, about twice the rate. And smoking, about 40 to 50% higher among lesbian, gay, and bisexual folks. And let's take a look at the last slide where I just tried to summarize, the next one, please, where I just tried to summarize some of the potential reasons. Next slide, please. Well, these are differences between transgender rates and U.S. population. Again, the data aren't as good. Serious psychological distress, 7 times higher. Ever attempted suicide, as somebody mentioned, 9 to 10 times. Suicidal thoughts, 12 times. Binge drinking and smoking also higher. Thanks. And Alex, do we have the last slide that I added as well? Maybe not. Okay. Yeah, sorry. Then let me, if you can go back for a minute, I'll say what was in another slide. What are some of the reasons for these differences? One of the main reasons for differences, and then I'll be done, Benji, and it'll be your turn. Main reason for differences in chronic illness: smoking. Smoking is so much higher among lesbian, gay, and bisexual populations, and that has a huge effect on heart disease, on diabetes, on stroke, which wasn't even there, and on a whole bunch of cancers. That is a major reason for differences in chronic illness. Another one, stress of discrimination. That is daily. Hypertension is stress related. Diabetes is stress related. Obesity, which I haven't shown yet, stress related. And as a result of significantly higher rates of trauma and violence experience, that often results in substance use, alcohol or illegal drugs or tobacco as a way to cope, with the trauma and violence that people have experienced. So just wanted to put a little context in sort of why these differences, both in behavioral health, but also in chronic illness. Smoking is huge, and then stress, stress, trauma, also homelessness. You know, the kinds of trauma that hugely has an impact on mental health and substance use as a way to deal with the difficult lives that folks deal with. Thank you. Benji.
Well, thank you, Rick, for a great intro with your data, because it does help Casper. So hello, everybody. I'm Benji Rapp, and I am here to share a resource for you and also share some perspectives. So the Cancer Screening Project, also known as CEnR, aims to help offering free coordination and navigation services for colorectal, cervical, breast, lung cancer for people living with HIV in the state of Michigan. Next slide. And I think you can go one more too. Thank you. So what I want to share with you, just a perspective, is that the Health Insurance Portability and Accountability Act protects the privacy of people living with HIV very well in the state of Michigan. However, it makes it difficult to report on topics. There aren't many people that want to share their statistics, their data, their life when it comes to releasing their status also. So it becomes difficult. It's data that's never really existed when it comes to HIV and cancer. The data just has never existed before. Casper is looking to build that data and also offer coordination, navigation, and resources for this specific community. What I'd like to do is something that's a little bit different. I want to share a perspective of the person living with HIV, living in the state of Michigan. And how we did this is we did key informant interviews, which is one-on-one interviews with people living with HIV in our state. And we spoke with them. We got their stories. When we got those stories, we combined aspects of the 27 different individuals, which did include providers and patients living with HIV. And we created what we call personas, a persona of an individual in the state of Michigan living with the virus HIV. So I'd like to get started with the first one so let's go for a walk in someone else's shoes. Next slide, please. So let's get comfy cozy, relax, and just close your eyes a little bit. You are Michelle, a 65-year-old cisgender lesbian white woman living with HIV who recently retired and moved to a rural area in the Upper Peninsula of Michigan. You are enrolled in Medicaid and are newly enrolled in Medicare. You have an HIV case manager helping you manage your medical care and other services. You see one of the only infectious disease doctors in the UP, which is several hours away by car. Your infectious disease doctor has recommended that you be screened for lung cancer and writes an order for a low-dose CT scan. You immediately feel irritated that your previous doctor and case managers at your last clinic were not proactive about bringing up these screenings and gave you the attention necessary in order to address that issue. You have never heard of a low-dose CT scan or a lung cancer screening, and you don't know why anyone has done it. You want to know what's happening with your health, so you want to start the screening process as soon as possible, but you run into issues with your distance, your sexuality, the fact that you have HIV, and you're afraid. You don't really know what your next choice is because it's difficult, and there's several barriers in the way. That's our first example with Michelle. Again, keep in mind, Michelle is a persona, not a real living person. Next slide, please. Next, I'd like to introduce you to Mike. So Mike is another persona that we've created by combining our key informant individuals. And this is a specific statement that we got from those interviews. I survived HIV, and that has been my main focus for most of my life. I wasn't even thinking about cancer. Next slide, please. So you are a 45-year-old Black man living in Southeast Michigan. You identify as homosexual, and you were recently diagnosed with HIV 2 years ago. You work part-time and you're enrolled in Medicaid. You see an infectious disease doctor regularly, but you do not have a primary care physician. You have a medical case manager or social worker, but you haven't met with them in over a year. You recently turned 45, and your infectious disease specialist recommended that you get screened for colorectal cancer, telling you that you're at the right age to get screened. Your infectious disease doctor cannot perform the screening in their clinic, so they write you a referral for a cancer screening at a local gastroenterologist. You really do trust your infectious disease doctor, has the best interest in mind, and you've heard that men should have colonoscopies, but you feel hesitant to go through with it. So you don't follow through with the referral after being recently diagnosed with HIV because you have a fear of transportation issues and asking for family for help because you remind yourself, I just told them I have HIV. I don't want to have to deal with the questions of why I'm having a screening done on colorectal cancer. So these two examples are living, breathing examples of what people struggle with within the HIV community in the state of Michigan. And it's difficult to understand those situations. That's why I like to really share these personas and talk to you folks in a way like you. Imagine yourself in this situation and how would you react? So a lot of folks made many, many statements during our key informant interviews that they are currently surviving HIV and they can't imagine having to stack the diagnoses on top of that, including a cancer diagnosis. Well, one thing I can tell you all as a resource is within Casper, if you ever need assistance in this situation, please refer the patient to the Cancer Screening Project. Our website is available on MDHHS, and I will try to share that with everyone also. But also keep in mind, if someone is treated for HIV, that means they're undetectable and untransmittable. It does not increase the risk of cancer, which is quite shocking. A lot of people think if you have HIV, you probably are more likely to get a lot of forms of cancer. That's not the case. What they found is the virus doesn't increase your risk of cancer. But like Rick has showed us prior, the lifestyle choices of that individual can increase risk, not the virus. So what we tend to see with this population is it's their smoking habits, their drinking habits, drug usage, and other social aspects of their life that have significantly multiplied their risk for colorectal, cervical, breast, and lung cancer. This population has been othered in many ways that they may not have received the same education when it comes to their diet, their health, or non-smoking aspects to live a healthy lifestyle. And that's where we're seeing increases of people dying from cancer in this specific population. If you look at John 2, we can notice that he wants to ask for HIV support. He just doesn't really know who to go to. He also has fears about the procedural prep. Anybody out there that's had to, I have not had to have a colonoscopy yet, but if you've had to drink that horrible liquid, it is not something that people look forward to in any way. And also understanding that there are other treatments or other screenings available out there. And the other treatments include, if you've seen the commercials of the walking Cologuard box, not everybody, maybe this person, especially Michelle, may benefit from having a Cologuard box mailed to her address rather than having to drive several hours. That's something that needs to be reviewed by her provider, of course, but it should be given as an option to her. And there's other colorectal cancer screening options that are available that didn't exist several years ago. That's the information that I have to share with you folks today. So I'd just like to share one more quote with you all, and I believe that's on my next slide. Finding out the results of being positive, it'd be a new factor in my life that I have to deal with. I think that would make me upset, because anything on top of HIV would make the HIV worse. I just don't want that to happen because of how many difficulties I've been through. I don't want to add anything on top of it. And that's something that people need our assistance when they're dealing with dual chronic diseases. And then in the next slide, I'd like to share this conversation with everyone. How do you feel after putting yourself in those shoes? What thoughts are coming forward for you as an individual in that type of a situation? And did anything surprise you? I think you can slide forward. My contact information should be on the last slide. Thank you.
Benji, thank you. Thank you very much. And so these are our final presentations for the day about major health needs in the LGBTQ communities. And remember, we are now going to go to our final breakout groups. You'll be back with your same group for the last time. And in some ways, this is, sort of an especially important conversation. And your note taker and facilitator will help sort of put out there all the things you've talked about today, so that each group can come up with a small number. One would be nice, but 2 or 3 would be okay, of what you think might be the highest priority items your group would recommend that work groups that follow up on this meeting would actually start to work on. So we're looking for 1 to 3 high priority action items. Yes, we have 30 minutes for the conversation. Then we will all get back into the main room and each group will present their main priorities across all the topics, right? So this is from all of our topics, the 3 discussions we've had, as well as the major health needs. 1 to 3 priority action items from any or combinations of those topics that your group thinks might be most important or useful in affecting the health and lives of the LGBTQ communities. And then at 3 o'clock, we will all share our priorities and then conclude. Okay? So back for our last discussion. Again, Benji, thank you.